4 days ago, on the 14th of July, the Centers for Medicare and Medicaid Services published a document that decides how much your doctor is paid to sit in a room with you. The number went down. Again. By the time this ends, you will know exactly why your Medicare premium keeps climbing, while the payment to the person who actually examines you keeps falling, and what that widening gap quietly does to your ability to get an appointment at all. Here is the number. Under the proposed rule for calendar year 2027, the payment rate that Medicare uses for most physicians drops to $32.84. It is $33.40 right now. That is a cut of 56 cents, or 1.68%. For physicians who participate in what Medicare calls an advanced alternative payment model, the rate falls to $33.17, down from $33.57. A cut of 40 cents, or 1.19%. 56 cents. You are probably thinking that 56 cents is nothing. That is the reaction the system depends on. But that number is not the price of a visit. It is the multiplier that every single service in Medicare Part B is measured against. Every office visit, every skin biopsy, every cardiology consultation, every 20-minute conversation about whether you should keep taking a medication. All of it is priced by taking that one number and multiplying it. When that number moves, everything moves with it across roughly 1 billion services a year. And here is the part that makes this worth 40 minutes of your attention. This is not the first cut. It is not the second. According to the American Medical Association, when you adjust for inflation, Medicare payment to physicians has fallen 33% between 2001 and 2025. A third. Gone. Over the same 24 years, the cost of running a medical practice went up, the cost of staff went up, the cost of rent went up, and the cost of the electronic record system the government required them to buy went up. Now hold that next to something else. Your standard Medicare Part B premium in 2026 is $202.90 a month. That is an increase of $17.90 over last year, a jump of 9.7%. So the amount taken out of your Social Security check for Part B rose almost 10% in 1 year. And the amount paid out to the physician on the other end of Part B is being proposed to fall for the 7th consecutive year. Money is going into the system faster. Money is coming out of the system slower. Somebody is standing in the middle of that gap. This video is about who and about what it costs you when you finally need to be seen. There is one more thing about last week that almost nobody outside health policy noticed, and it is the reason this story is not simply another round of bad news. Exactly 1 day after that rule dropped, on the 15th of July, 3 members of Congress who are all practicing physicians walked in and filed a bill designed to end this cycle permanently. Not to patch it for 1 year the way Congress has patched it almost every year for a decade, to change the formula underneath it. That bill has a name, it has bipartisan sponsors, and it has a specific mechanism that I am going to explain in plain English, because if it passes, it changes the math on your access to care for the rest of your life. If it dies, the erosion you have watched for 25 years simply continues on schedule. So there are 2 documents from last week sitting on the table. One of them cuts. One of them tries to stop the cutting. Both of them are about you, even though neither of them mentions you by name. Stay with me because before we get to either one, you need to understand the single strangest fact in this entire story. Congress actually voted your doctor a raise last year. It passed. It became law, and it is the direct reason the payment is falling right now. Let us be precise about what happened, because precision is what separates this from the noise you scroll past. On Tuesday, the 14th of July, 2026, the Centers for Medicare and Medicaid Services, the federal agency that runs Medicare, issued what is formally called a proposed rule. Its full title is a mouthful: Medicare and Medicaid Programs, Calendar Year 2027 Payment Policies under the Physician Fee Schedule and other changes to Part B payment and coverage policies, Medicare Shared Savings Program requirements, and Medicare Prescription Drug Inflation Rebate Program. It was formally published in the Federal Register 2 days later, on the 16th of July. The American Hospital Association reported the release on the day it came out. Comments from the public, from physicians, from hospitals, from anyone who wants to file one, are due by the 14th of September. If the rule is finalized in roughly its current shape, it takes effect on the 1st of January, 2027. Now, the word proposed matters here, and I want to be honest with you about it rather than sell you urgency that is not real. This is not law yet. It is a proposal, and it is genuinely open to comment for the next 2 months. Things in proposed rules do change before they are finalized. But do not mistake proposed for unlikely. The core of this particular cut is not a discretionary choice that CMS made and could simply reverse after reading angry letters. It is arithmetic that flows from statute. CMS is largely reporting a result, not choosing one. That distinction is the whole reason the physician groups went to Congress the next day instead of just filing comments with the agency. They understand that the agency does not have the authority to fix this. Only Congress does. The rule itself is enormous. It covers far more than the payment rate. It changes how Medicare calculates the overhead costs of running a practice. It restricts payment when an office visit happens on the same day as a procedure by the same practice. It adds services to the telehealth list. It raises the valuation of certain behavioral health services. It reforms the Medicare Shared Savings Program, which is the accountable care organization system that roughly 11 million people in traditional Medicare are already assigned to whether or not they know it. It converts a drug pricing data submission from voluntary to mandatory starting in 2027. We are going to get to all of it. Some of it is genuinely good news for you, and I am not going to hide that in order to keep this dramatic. But the headline, the thing every physician organization responded to within 24 hours, is the conversion factor. I want to describe what that agency release actually looks like, because the mechanics of how this reaches you are part of the story. CMS does not announce this on television. There is no press conference. A fact sheet goes up on the CMS newsroom page. A document goes to the Federal Register. Trade publications for physicians and hospitals write it up within hours. Specialty societies issue statements. Consultants publish summaries for their clients. And then, at no point in that chain, does anyone place a telephone call to the 8-year-old Medicare beneficiary in Ohio who is going to have a slightly harder time finding a rheumatologist in 18 months. Sorry, the 68-year-old. That is the point. The chain of communication runs from the agency to the industry, and it stops there. You are the person the entire structure exists to serve, and you are the only party who finds out about it last, usually by experiencing it rather than by reading it. That is what this channel is for. So let us go to the number itself, because until you understand what a conversion factor actually is, none of the rest of this will land properly. Medicare does not pay your doctor a price. It pays your doctor a score, converted into dollars. Understanding that one sentence will make you better informed about American healthcare than most people who work in it. Here is how it works. Every service a physician can perform has a code. There are roughly 10,000 of them. A standard office visit for an established patient with a moderate problem has a code. A knee replacement has a code. A 20-minute discussion about your advanced care planning has a code. Each code is assigned a value called a relative value unit, which everyone shortens to RVU. The RVU is not money. It is a measure of relative effort and cost. It has 3 parts. The work component, which is the physician's time, skill, mental effort, and risk. The practice expense component, which is the rent, the staff, the equipment, the supplies. And the malpractice component, which is the insurance cost of doing that particular thing. Those 3 parts are added up, adjusted for the region of the country where the practice is located, because rent in San Francisco is not rent in rural Kansas, and that gives you a total RVU figure for that service in that place. Then comes the conversion factor. It is one single national number, expressed in dollars, and Medicare simply multiplies. Total RVUs times the conversion factor equals the payment. That is it. That is the entire pricing system for Medicare Part B physician services. One number applied to everything. Which means the conversion factor is a lever with a very long arm. Move it 56 cents and you have not adjusted one service. You have adjusted the price of every service simultaneously, in every specialty, in every state, for every one of the roughly 68 million people enrolled in Medicare. So when the AHA reports that the non-qualifying conversion factor falls from $33.40 to $32.84, understand what is being said. A practice that took in $100,000 from Medicare this year, doing exactly the same work with exactly the same patients, takes in roughly $98,300 next year. Nothing about the work changed. Only the multiplier did. Now, why are there two conversion factors? Because of a law passed in 2015 called MACRA, the Medicare Access and Chip Reauthorization Act. MACRA split physicians into two lanes. If you participate in what Medicare calls an advanced alternative payment model, where you take on financial risk for the total cost and quality of your patient's care, you get the higher conversion factor and a statutory annual update of 0.75%. If you stay in the standard lane, you get the lower conversion factor and a statutory annual update of 0.25%. 0.75%, 0.25%. Hold those two numbers in your mind for a moment and compare them to anything in your own life. Compare them to what your grocery bill did last year. Compare them to your Part B premium, which rose 9.7%. That is the designed, permanent, written into federal law annual update for the people who deliver your medical care. 0.25%. And here is the sentence that should stop you. Those statutory updates are not tied to inflation in any way. There is no index. There is no adjustment for the cost of running a practice. Congress wrote a fixed number into law in 2015, and that fixed number is what applies forever until Congress writes a different one. There is a measure of medical practice inflation. It exists. It is called the Medicare Economic Index, and the federal government calculates it every year. It is simply not used to set this payment. Remember that name. It becomes the center of the story in a few minutes. But first, the strangest part. Because the cut we are discussing is not caused by the 0.25% update being too small. It is caused by something Congress did that was meant to help. In 2025, Congress noticed the problem. Physician groups had been warning for years that the payment rate kept falling in real terms and that independent practices were closing. So lawmakers acted. Attached to the tax legislation that passed as the Working Families Tax Cut Package, Congress included a temporary increase of 2.5% to the physician conversion factor for calendar year 2026. Not permanent, temporary. 1 year. That increase is the reason your doctor's Medicare payment went up this year. It is also, precisely and entirely, the reason it is going down next year. Watch the arithmetic. For 2027, CMS starts by applying the statutory updates written into MACRA, 0.75% for the alternative payment model lane and 0.25% for the standard lane. Then it applies an adjustment of 0.53% related to changes in the work relative value units. Both of those are positive numbers. They push the payment up. And then the 2.5% increase that Congress granted for 2026 expires, because it was written to expire, and it comes back out. Add a small positive, add another small positive, subtract 2.5, you land below where you started. That is the entire explanation for the cut. There is no villain in that paragraph. There is only a temporary patch reaching its expiration date. This is the pattern I need you to see clearly, because once you see it, you will recognize it every single year for the rest of your life as a Medicare beneficiary. Congress does not fix the formula. Congress suspends the consequences of the formula for 12 months, calls it a fix, and goes home. The following year, the suspension lapses and the formula resumes exactly where it left off, except now the lapse itself reads as a fresh cut. So physicians experience a cut, Congress feels pressure, Congress passes another temporary patch, and the cycle repeats. Health policy people have a name for this. They call it the doc fix. The Committee for a Responsible Federal Budget published a piece in May of 2026 titled simply, "The Next Doc Fix is Coming." They were not making a prediction. They were reading a calendar. Here is why the pattern is worse than it sounds. A permanent increase compounds. A temporary one does not. If Congress had made that 2.5% permanent, it would sit in the base forever and every future year would build on top of it. Because it was temporary, it evaporates completely, and the base returns to where it would have been if Congress had never acted at all. 25 years of temporary patches leave you exactly where 25 years of no patches would have left you. That is not an accident of drafting. It is a budget technique. A temporary provision costs the federal budget far less on paper than a permanent one, because the official cost estimate only counts the years the provision exists. Making it permanent would require finding offsetting savings somewhere else, and finding offsetting savings inside Medicare means cutting something that has a constituency. So the temporary patch is the politically cheapest available action that still allows a member of Congress to say, truthfully, that they voted to increase physician payment. They did. It just does not accumulate. And the compounding effect of 25 years of non-accumulation is the 33% figure we are about to look at directly. One more consequence of this design, and it is the one that touches your care most immediately. Physicians cannot plan. A medical practice is a small business. It signs leases, it hires nurses, it buys equipment on multi-year terms. Try running that business when your largest single payer changes your rate every 12 months by an amount you cannot know until July and cannot confirm until November. The instability is not a side effect of the temporary patch. It is the direct product of it. Now let us put the whole span on the table, because a single year of 1.68% means very little, and a quarter century means everything. According to the American Medical Association, adjusted for inflation, Medicare physician payment declined 33% from 2001 to 2025. Sit with that. If the payment for seeing a Medicare patient had simply held even with the cost of living since 2001, it would be roughly 50% higher in nominal dollars than it is today. How did that happen without anyone deciding it? Because of exactly the mechanism we just walked through. The AMA explains it directly. Since 1992, the role of the Medicare Economic Index in setting physician payment has been steadily reduced, first under a system called the Sustainable Growth Rate, and then under MACRA in 2015. Two different formulas, 30 years apart, both of which had the same effect. They cut the link between what it costs to deliver care and what Medicare pays for it. Compare this to how the rest of Medicare works, because the contrast is the thing that makes this indefensible rather than merely unfortunate. Hospitals get an annual update tied to a market basket index that reflects their actual costs. Skilled nursing facilities get an update tied to their costs. Home health agencies get one. Hospices get one. Your own Social Security benefit gets a cost of living adjustment every year, 2.8% for 2026, tied to a consumer price index. Almost every payment stream in this system is indexed to something real. Physician payment is the exception. It is fixed at 0.25% by statute regardless of what anything costs. This is not a fringe complaint from a trade group protecting its members. The Medicare Payment Advisory Commission, MedPAC, is the independent, nonpartisan body that Congress created specifically to advise it on Medicare payment. It is not a lobbying organization. At its meeting in April of 2026, MedPAC voted to recommend that Congress replace the current statutory updates with a portion of the Medicare Economic Index, specifically the index minus 1 percentage point, every year going forward. Read the evidence MedPAC weighed before that vote, because it is the clearest official summary of where this has arrived. Physicians facing a fifth consecutive year of payment cuts while medical inflation stayed high. Physicians abandoning private practice. And patients, especially in rural and underserved areas, facing obstacles to accessing care. That third item is you. That is the government's own advisory commission stating, in the record, that the payment formula is now producing access problems for patients. Now I want to be careful and fair here, because this is where these videos usually go wrong. Some of the 33% decline reflects real changes in how medicine is delivered. Procedures that took 2 hours in 2001 take 40 minutes now. Technology genuinely reduced the effort of some services, and the payment for those services arguably should have come down. But that explains a portion of the decline. It does not explain a formula with no inflation adjustment at all, applied uniformly to a cognitive office visit with a 75-year-old managing 6 chronic conditions, which has not gotten faster, easier, or cheaper. If anything, it has gotten harder, because that patient now has more medications, more specialists, and more records to reconcile than they did in 2001. The formula does not distinguish. It cannot. It is one number applied to everything. Everything up to now has been mechanics. This section is consequence. What does a formula that erodes for 25 years actually do to a person who needs to see a doctor? Start with the honest data, not the alarming version. KFF, the Independent Health Policy Research Organization, has tracked physician acceptance of new Medicare patients for years, and the top-line numbers are more stable than the rhetoric suggests. In 2011, 88% of non-pediatric office-based physicians accepted new Medicare patients. In 2019, that figure was 89%. So the story is not that doctors are fleeing Medicare in a wave. They are not. Medicare acceptance remains high, and it remains close to private insurance acceptance. Among primary care physicians specifically, KFF found 83% accepting new Medicare patients against 86% for new privately insured patients. A gap of 3 points, not a chasm. I am telling you this because you deserve the real number, and because the real number is bad enough without inflation. Look at where the pressure actually shows. That 83% figure among primary care physicians is a national average, and national averages conceal geography. MedPAC did not say patients face obstacles. It said patients in rural and underserved areas face obstacles. A practice in a wealthy suburb with a diversified payer mix can absorb a Medicare rate that erodes 1 or 2% a year. A 2-physician practice in a rural county where 70% of the patients are on Medicare cannot. The same national cut produces a shrug in one place and a closure in the other. The second place it shows is in specialty and in time. When the rate falls, a practice does not usually announce that it is dropping Medicare. It adjusts quietly. It caps the number of new Medicare patients per month. It stops taking new Medicare patients while keeping every existing one. It shortens the visit. It stretches the interval between follow-ups from 3 months to 5. None of that is refusal. All of it is rationing by friction, and you experience it as a waiting room and a calendar rather than as a policy. The third and largest effect is the one MedPAC named directly: physicians abandoning private practice. When a small practice cannot make the arithmetic work, the owner sells to a hospital system or a private equity-backed group. The physician does not leave medicine. The independent practice leaves the map. Consolidation has a documented price for you, and it is not subtle. When a physician practice is acquired by a hospital, the same service performed by the same physician in the same building can be billed at hospital outpatient rates instead of physician office rates. Medicare pays more, and because your Part B coinsurance is 20% of the allowed amount, you pay more too. Your bill for the identical appointment goes up because the sign on the building changed. Sit with the full circle of that. A policy designed to reduce Medicare spending pushes practices into hospital systems where the identical service is priced higher, which raises Medicare spending and raises your out-of-pocket costs simultaneously. The savings on paper become a cost in reality, and you pay a share of it. There is a fourth effect, and it is the quietest of all. It shows up in who chooses this work in the first place. A medical student finishing training carries an average debt load north of $200,000. That student is choosing a specialty. On one side sits primary care, geriatrics, and internal medicine, the fields that see the most Medicare patients and depend most heavily on the office visit codes that this formula governs. On the other side sit specialties with more procedures, more private insurance, and more revenue that the fee schedule does not touch. Geriatrics is the clearest case. It is the one specialty defined entirely by caring for the population we are discussing, and it is chronically among the least chosen in the residency match. Programs go unfilled every year. The country is adding roughly 10,000 people a day to the age at which geriatric care becomes relevant, and the pipeline of physicians trained specifically to provide it is not growing to meet it. No formula caused that alone, but a payment system that has fallen a third in real terms over 25 years, concentrated on exactly the cognitive office visit work that geriatrics consists of, is not a neutral bystander to that choice either. 22-year-olds read incentives accurately. They are reading these. And the effect of that decision compounds on a delay of about a decade. The physician who chooses a different specialty in 2026 is the geriatrician who is not available in 2036. By the time the shortage is visible in your own appointment calendar, the decision that produced it is 10 years in the past and entirely unfixable. That is why the payment formula is not an inside baseball topic about doctor income. It is a structural force acting on where medicine is practiced, who owns it, how long your appointment lasts, how far you drive, and what you are charged when you arrive. Which brings us to the second document from last week, the one that tries to stop this. On the 15th of July, 2026, one day after the CMS rule was released, 3 members of the House of Representatives introduced legislation called the Patient's First Act. Look at who filed it. Representative John Joyce of Pennsylvania, a physician, and Representative Greg Murphy of North Carolina, also a physician, who together co-lead the Republican Doctors Caucus. Alongside them, Representative Kim Schreier of Washington, a physician, who leads the Democratic Doctors Caucus. 2 Republicans and 1 Democrat, all 3 of them practicing physicians before they were legislators. Both party doctors' caucuses represented. Fierce Healthcare noted that the proposal came the day after CMS released the 2027 fee schedule with its cut to the conversion factor. That timing was not a coincidence. It was a response. Here is what the bill actually does, in 4 parts. First, and most importantly, it replaces the MACRA formula. Instead of the fixed statutory updates of 0.75% and 0.25%, physician payment would be tied to the Medicare Economic Index minus 1 percentage point. That is the same mechanism MedPAC recommended in April. The index that measures what it actually costs to run a medical practice would finally drive the payment, with a 1-point haircut built in as a nod to productivity gains and to budget cost. Understand what that single change means. It converts physician payment from a fixed number that Congress must repair by hand every year into an index number that adjusts automatically. It ends the doc fix cycle by removing the thing that requires fixing. Second, the bill caps volatility. Year-to-year changes in the conversion factor would be limited to 2.5% in either direction. No sudden swing large enough to close a practice, and no windfall either. Predictability, which is the thing a small business needs most, and the thing this system has denied physicians for a decade. Third, it adjusts something technical that has real consequences, called the budget neutrality threshold. Under current law, if changes to how services are valued would shift more than $20 million in spending, CMS must adjust the conversion factor downward to keep the total neutral. $20 million was set decades ago and has never been updated for inflation, so in practice, almost any meaningful revaluation triggers a cut to everyone. The bill raises that threshold to $57.6 million and indexes it to inflation every 5 years. It means fewer automatic across-the-board cuts triggered by ordinary technical updates. Fourth, it creates a primary care hybrid payment pilot. Independent physicians could receive a per-member per-month payment for each patient alongside some traditional fee for service reimbursement. Medical Economics reported the sponsors framing this explicitly around bolstering independent practice and fighting healthcare consolidation, which is the exact problem MedPAC flagged. The response from physician organizations was immediate. AMA President Willie Underwood III issued a statement on the 15th of July commending, in his words, the bipartisan leadership of the Republican and Democratic doctors' caucuses for proposing solutions to stabilize physician payment and protect access to care. Fierce Healthcare described the reception among providers as resounding applause. The American Society of Anesthesiologists and the California Medical Association issued their own statements of support within days. Now the sober part, and I am not going to sell you false hope. Introduction is not passage. Bipartisan introduction is not passage either. This bill has 3 sponsors, and it has to move through the House Ways and Means Committee and the Energy and Commerce Committee before it goes anywhere near a floor vote. Tying physician payment to an inflation index costs the federal budget real money over 10 years, and that cost has to be offset. Every previous attempt at this reform has died on exactly that question. What is different this time is the alignment. MedPAC recommended the mechanism in April. The doctors' caucuses filed the mechanism in July. The agency itself is publishing a cut it cannot prevent. That is an unusual amount of agreement about both the problem and the solution. Whether agreement becomes law is the thing to watch, and I will tell you exactly when to watch it in the final section. The conversion factor got the headlines, but the rule is hundreds of pages long, and several other pieces in it will touch you directly. Some of them are genuinely good. Start with telehealth, which for anyone over 65 has become one of the more consequential parts of Medicare. CMS proposes adding 5 codes to the Medicare telehealth list, and among the services proposed for addition are advanced care planning and shared medical appointments. Advanced care planning is the conversation about what care you want and do not want if you cannot speak for yourself. Making that reimbursable by video is a meaningful change for anyone with mobility limits or anyone whose adult child lives 3 states away and wants to be on the call. CMS also proposes creating 2 new telehealth billing modifiers, which it is required to do under the Consolidated Appropriations Act of 2026, and clarifying critical care consultation code descriptors. It proposes allowing physicians to bill for telehealth involving residents when either the teaching physician or the resident is physically in the room with you, which matters if you get your care at an academic medical center. On the broader question of whether telehealth survives at all, CMS used the rule to remind everyone where the statutory deadlines now sit. Most telehealth flexibilities are extended by Congress through the 31st of December, 2027. Audio-only telehealth authority runs through the 1st of January, 2028. The geographic and originating site restrictions, which before the pandemic meant you generally had to be in a rural area and physically inside a clinic to use telehealth at all, remain waived through 2027. Note the shape of that, extended, through a date, which means telehealth is on exactly the same temporary patch cycle as physician payment, and it has its own cliff waiting at the end of 2027. Second piece, behavioral health. In the 2024 fee schedule, CMS raised the valuation of timed behavioral health services by applying an upward adjustment of 19.1% to the work relative value units for time-based psychotherapy codes. In this proposed rule, CMS extends that same 19.1% adjustment to smoking and tobacco use cessation counseling and to screening, brief intervention, and referral to treatment services. That is a real increase, in the opposite direction from the conversion factor, aimed at services that are chronically underpaid and chronically underdelivered to older adults. Third, practice expense methodology. CMS proposes reducing its reliance on specialty-specific practice expense per hour data and modifying how indirect practice expense is calculated for skilled nursing facility stays. This sounds like nothing. It is not nothing. Practice expense is a large share of total RVUs, and changing the method reallocates money between specialties. Some specialties gain, some lose, and the ones that lose will spend the comment period explaining why. Fourth, evaluation and management restrictions. CMS proposes new limits on payment when an office visit occurs on the same day as a global procedure performed by the same physician or the same practice. In practice, this means fewer situations where a practice can bill separately for the conversation and the procedure on one visit. Fifth, the Medicare Shared Savings Program. CMS proposes further reforms to increase savings in the two-sided risk tracks and attract new accountable care organizations, including an updated beneficiary assignment methodology. If you are in traditional Medicare, you may already be assigned to an accountable care organization without ever having chosen one. Changing the assignment methodology changes which organization is accountable for your care. Sixth, the Quality Payment Program adds 3 new MIPS value pathways, with revisions emphasizing patient-reported outcomes and chronic disease management. Patient-reported outcomes means your own account of whether you can climb the stairs starts counting toward how your physician is scored. And seventh, the one with the longest tail. CMS proposes converting 340B Medicare Part D claims data submissions from voluntary to mandatory starting in 2027. The 340B program lets certain hospitals and clinics buy drugs at deep discounts. Nobody has reliable data on what happens to those discounts. Making the reporting mandatory is how you find out, and finding out is how a future rule gets written. Now put the two ends of Medicare Part B side by side, because this is the comparison that almost never gets made in public. The money going in. Your standard Part B premium for 2026 is $202.90 a month. That is up $17.90 from 2025, an increase of 9.7% in a single year. It is deducted directly from your Social Security payment before the money reaches your bank account. Your 2026 cost of living adjustment was 2.8%, which raised the average retired worker's benefit by roughly $56 a month to about $2,071. Subtract a $17.90 Part B increase from a $56 raise, and roughly $38 survives. CNBC ran that arithmetic when the figures were announced. Nearly a third of your raise was consumed by the premium before you saw it. The money going out. The payment to physicians is proposed to fall 1.68%. Premiums up 9.7%. Physician payment down 1.68%. Same program, same year. Now I have to be straight with you, because the honest explanation matters more than the outrage. Those two numbers are not directly connected the way it looks. Your Part B premium is set to cover roughly 25% of total Part B spending, and total Part B spending is driven far more by drugs administered in physician offices, by outpatient hospital care, and by rising volume of services than it is by the physician fee schedule. Physician services are a minority of Part B spending. Premiums can rise sharply while physician payment falls, without contradiction, because the growth is happening elsewhere. But being explainable is not the same as being acceptable, and here is where it lands on you. You are paying 9.7% more this year for a program whose payment to the person who actually examines you is falling. Whatever the money is buying, it is not buying more time with your physician. The share of Part B going to drugs and facilities is rising, and the share going to the office visit is shrinking. That is a decision about what American medicine values, made through a formula rather than through a debate. And then there is the piece that comes directly out of your pocket. Under Part B, you pay 20% coinsurance on the Medicare-approved amount, with no annual out-of-pocket cap in traditional Medicare. Remember the consolidation effect. When your physician's practice is acquired by a hospital system and the same appointment is billed at hospital outpatient rates, the approved amount goes up. 20% of a larger number is a larger number. So the erosion of physician payment reaches your wallet through a route almost nobody traces. It does not raise your bill directly. It changes who owns the practice, and the new owner bills under a different and higher schedule, and your coinsurance follows. One more consequence worth naming plainly. Roughly half of Medicare beneficiaries are now in Medicare Advantage plans, and Medicare Advantage payment rates are largely benchmarked to traditional Medicare rates. When the fee schedule falls, the reference point for a large share of private plan contracting falls with it. This rule does not stop at the boundary of traditional Medicare. It moves the floor under both. There is one group for whom the premium side of this lands harder still, and it is worth naming because most people do not know they are in it until the letter arrives. If your modified adjusted gross income 2 years ago exceeded the threshold, you do not pay the standard $202.90. You pay an income-related monthly adjustment amount on top of it, which climbs through several brackets. And the income Medicare uses is your income from 2 years back, which means a single unusual year, selling a house, taking a large distribution to cover a roof, converting an account to a Roth, can raise your premium for a year that has nothing to do with the year that produced the income. So the premium side of Part B is not one number rising 9.7%. For a meaningful share of beneficiaries, it is a considerably larger number, indexed to a financial decision they made 2 years earlier and may have forgotten about. Set that against the other end of the same program, where the payment for the office visit is proposed to fall for the 7th straight year, and the asymmetry is complete. The contribution side of Part B is finely calibrated. It has brackets, thresholds, look-back periods, and annual adjustments. It knows precisely who you are and what you earned. The payment side is one flat national number with no inflation adjustment at all. The system built exquisite machinery for collecting and left the machinery for paying frozen in place in 2015. That is the full shape of it. A number most people have never heard of, moving 56 cents, reaching your appointment, your drive, your waiting time, and your bill. Here is what happens next with dates, so you can follow this yourself instead of waiting to find out by experiencing it. The 14th of September 2026 is the comment deadline on the proposed rule. Anyone may file a comment, including you. Comments go through the Federal Register listing for the rule. Physician organizations, hospital associations, and specialty societies will file detailed ones. CMS is legally required to respond to substantive comments in the final rule. Then watch for the final rule, which normally arrives in early November for a 1st of January effective date. Compare the final conversion factor to the proposed $32.84. If it is unchanged, that confirms what the physician groups already concluded, that CMS lacks the authority to fix this and only Congress can. Which makes the third thing the one that actually matters. Watch whether the patient's first act moves, not whether it is praised, whether it gets a committee hearing, whether it gains co-sponsors beyond the 3 sponsoring physicians, and above all, whether its Medicare Economic Index -1 point formula gets attached to a larger must-pass vehicle in December. That is how this kind of provision has always traveled. It rides on a year-end package, or it does not travel at all. And watch for the alternative outcome, because it is the most likely one. Congress passes another temporary patch for 2027, restoring some or all of the cut for 1 year, and the entire cycle resets in July of 2027 with a new proposed rule and a new expiring increase. If that is what happens, you will know that the formula was not fixed. Only the symptom was. There is one more date on the horizon that belongs in the same frame. The telehealth flexibilities expire on the 31st of December, 2027, and audio-only authority on the 1st of January, 2028. Same structure, same cliff. So what can you actually do with this? A few things, and I want to frame them as what some people are considering rather than as advice. Some people use the annual Medicare open enrollment window, the 15th of October through the 7th of December, to confirm directly with their physician's office that the practice will still accept their coverage in the coming year, rather than assuming it. Some people, particularly those in rural areas, ask their primary care office one specific question well before they need an answer, which is whether the practice is still taking new Medicare patients, because that is the earliest visible signal that a practice is under strain. Some people who are seeing an independent physician they value ask directly whether the practice has been approached about acquisition, since a change in ownership can change what an identical appointment costs them under Part B coinsurance. And some people file a public comment or contact their own member of Congress about the patient's first act specifically by name, because a bill with 3 sponsors in July, becomes a bill with 80 sponsors in December only if constituents mention it. The takeaway I want to leave you with is this. The most consequential decisions about your medical care are not announced. They are published. They arrive as a 56-cent change to multiplier in a document with a title so long that no headline can carry it, released in the middle of July when nobody is paying attention. And then they reach you 2 years later as a longer wait, a further drive, or a larger bill, and by then nothing connects the effect back to the cause. You now know the cause. That is worth more than the outrage. This video is for informational purposes only and does not constitute financial, legal, or tax advice. Laws and policies change. Always consult a qualified professional before making any financial decisions.